Heather Olden. I'm coming to you live from Detroit, Michigan. I feel like I'm a radio host. I am today's moderator for this esteemed breakout session. I'm so excited to hear what our speakers have to share today. Before we get started, thank you for coming. Thank you for bringing energy, being present. I hope you enjoyed today's session. I caught the beginning and I was so sad I had to go to check in here, but it sounded like it was a great dialogue. So I hope you're enjoying yourself. All righty, so let's jump right into today's, just a quick reminder. So we want to keep this experience a safe space. We've been talking about a safe space in all of the sessions. So let's keep it safe for everyone involved. Please feel free to enter your comments in the chat box or use the question panel to submit questions. And how we're going to do things is towards the end of the presentation, I'm going to go through the questions and try and filter out some of the ones that will help us have a really robust conversation and discussion. And if you ask some of the same questions, I'll try and combine them a little bit. I'll try and get to all of your questions, I promise. You may also address your comments or questions to specific presenters. We're monitoring the comments and questions like I mentioned, and we'll help to facilitate the responses based on the time we have in our program today. Please, while you're interacting with other attendees and symposium presenters, please be respectful of their ideas, address issues, please be solution-oriented. We are moving towards action in this symposium, and of course, maintain confidentiality. We also ask that you add to discussion on social media by using the following hashtags: #birthequity, #PCOR, PCOR, and #NMHPN. That's a mouthful. So with that, I'm going to go ahead and introduce our esteemed speakers today. I'll start with Dr. Lois McCloskey. She serves as an associate professor of the Department of Community Health Sciences, co-director of the MCH Maternal Child Health Certificate, and director of the Center of Excellence in Maternal and Child Health at Boston University School of Public Health. As an educator, she specializes in field-based courses in leadership and consultation and sexual and reproductive health advocacy. As a researcher and activist, she focuses on the links between reproductive health care and women's health over the life course. Lois's public health career began about 40 years ago as an applied anthropologist and educator of community health workers in Nepal. The work inspired her lifelong concern with the health care of women and their infants, particularly in communities that are underserved. In both international and domestic settings, she focuses on the disconnects between the lives of women and the healthcare systems meant to serve their needs across the life course, and proven strategies for engaging and activating women to be full partners in their reproductive health care and planning. Most recently, with grants from the National Institutes of Child Health and Development and NIDDK, Lois has led investigations on the reasons for exceedingly low rates of follow-up testing and prevention for women with gestational diabetes, a harbinger of risk type 2 diabetes, mellitus, I promise I can read, later in life. She is principal investigator of a PCORI-funded project entitled Bridging the Chasm Between Pregnancy and Women's Health Over the Life Course, designed to translate research findings and the lived experience of women into action at the national level. Lois completed an MPH in Population, Family, and International Health and a DrPH in Perinatal Epidemiology and Health Services Research with a minor in Medical Anthropology at UCLA School of Public Health. Dr. Irene Headen is an assistant professor of Black Health in the Department of Community Health and Prevention at the Drexel Dornsife School of Public Health. Her research interests investigate the social and structural determinants of racial and ethnic disparities in adverse pregnancy outcomes. In particular, her work focuses on identifying neighborhood and community factors underlying these disparities and understanding how systems thinking can help translate these factors into multi-level interventions to improve Black maternal health outcomes. Central to Headen's work is placing pregnancy within the context of women's reproductive life course and developing ways to understand how structural racism operates over the life course to create racial and ethnic racial and ethnic disparities during this critical window. She uses both epidemiologic and mixed method approaches to conduct her research. Headen received her doctoral degree in epidemiology from the University of California, Berkeley in 2015 and completed a postdoctoral training fellowship through the Maternal and Child Health Bureau's Center of Excellence in Maternal Health Postdoctoral Training Program. That is a mouthful. She also was a postdoctoral fellow at the Drexel Urban Health Collaborative before joining the faculty in 2019. Please help me in welcoming our esteemed guests, Doctors McCloskey and Headen. Thank you.
All right, thanks, Heather. And I'm going to start sharing my screen right now. And hopefully you are viewing the presenter view of our slides. So to start out, after that wonderful introduction, I think we can kind of dive right into kind of the content of the roundtable today. And this is really around presenting that work that Heather mentioned in the introduction that Lois has led around bridging the chasm between pregnancy and health over the life course. And I wanted to start out our discussion today by, we're going to talk about the agenda, we're going to talk about all of that, but I really wanted to center the discussion that we're having with the current moment, right? This work started before, the COVID pandemic and all of the racial uprisings, but as we're experiencing the current moment of enduring the dual pandemics of COVID-19 and racial injustice, we're really feeling the spotlight on the fact that there's this urgent need for change, and also there's this urgent capacity to change when we so choose to. And these two kind of reflecting pandemics show that COVID-19 has brought forth a lot of disruption, but a lot of change that's been met to address this disruption, whereas racial injustice and uprisings to address racial injustice have met with the same unacceptable stagnancy that has plagued structural racism in our country for centuries. And so in this moment, I was actually reminded of a quote that I came across very early in the pandemic when kind of the news of the racial disparities that were emerging across cases and deaths was starting to come down the pike. And this was a quote by author Arundhati Roy. And she was talking about the fact that this pandemic is putting a lens up to society, showing all of the inequities that are amplifying into unacceptable disparities in death and disease for Black and communities of color. But she also mentioned, or she also wanted to say that the pandemic can be a portal. It can be a portal for leaving behind what is not working. It can be a portal that when we step through it, we can radically advocate for bringing forth agendas and actions that will disrupt and make us no longer stagnant in the status quo that perpetuates these racial disparities. So I wanted to plant this seed of thought as we kind of navigate the background, navigate our discussion of this agenda. In our discussion, let's reflect on what do we want to bring through this portal? How can we leverage this agenda? How can we leverage our experiences? How can we leverage our radical kind of momentum for change to take through the portal the tools that will allow us to actually affect radical change in this area? So that's kind of a seed I want to plant as we're kind of thinking through the slides, and also that I think will kind of generate thoughts for our discussion portion of the presentation. So to just give a 100-foot view, these are the chasms that we're talking about. There are four main ones that Lois will then give a deeper background on why these chasms are the main ones that are really stagnating our ability to advance in both eliminating disparities in women's health and also eliminating or creating holistic approaches to women's care. And I'll give you the overview, but we'll be talking about these in depth. And so at this point, I will hand it off to Lois to talk more about why these 4 points, the background information informing why these 4 chasms are the ones that are the most immediate to address in the current time.
Thanks, Eileen. Let's go, if you would go back to that for just a moment. So Hi, everybody. And that I just want to comment that that metaphor that you raised, Irene, is so perfect in many ways. And it reminds me that, in fact, what this initiative really is all about, at one level, is that pregnancy itself for women is a portal to a window in, or a portal to health into the future. And that's why we talk about needing to bridge any chasms that there are after pregnancy, so that we're really as attentive to women's care beyond the birth of what everybody hopes is a very healthy baby. So quickly, these 4 chasms are just that. We tend to invest more in women while pregnant, not enough, but at least more than afterwards, that there's just a deep chasm that they fall into after the obstetric or the maternity care period is over. The second chasm is, of course, front and center, how we care and deliver health to white versus Black and other women of color and Indigenous people. The third, those who design systems and make policies, there's this huge divide between those with lived experience. And that's what this conference, that's what PCORI, that's what probably every one of us sitting here is trying to address in our work. And then we also found that there is, so in this very area we're talking about, there is so much knowledge, so much evidence that pregnancy tells us a whole lot about how women's underlying health is and what we need to pay attention to, but we don't do a darn thing, generally speaking. Of course, that's a broad generalization, but it is, from a systems point of view, very true. Okay, so just very quickly, a reminder, so we're all on the same page about what's underlying these chasms and what the data tell us. First of all, not only are there great racial and ethnic inequities in maternal and infant mortality, but also in chronic illness across the life course. So the next slide shows us what's really important. We're used to seeing this, I think, this radically unacceptable disparity between Black and white women's likelihood of dying within a year of childbirth. But also that 1/3 of these deaths occur after the official maternity care period is over, 1 week to the year postpartum, to 1 year postpartum. And the leading cause in that period is heart disease, is cardiac issues, cardiomyopathy and other such cardiac issues. Go ahead. This story we're familiar with, I'm sure, of Shanon Irving. Perhaps she's been brought up even today or during this symposium, because it is just such a reminder, I guess, of how stories encapsulate what goes wrong. And therefore, her tragic story can go on to inform policy. And it already is, because of the incredible determined work of her mother and other advocates. So these quotes sort of encapsulate that window that is left, that chasm, after women, even after having complications, go home and are left untended to or unlistened to. So I'll let you read those on your own. And then remind us of her mother, especially saying, if race weren't a precursor to how people are dealt with, this outcome could have and would have been different. And as Atul Gawande has said, no one told her that a high blood pressure when she went home was a 911 emergency. Now, she was extremely smart and well educated, but we all know how for our own health, we're less likely to be alarmed, right? So her death was absolutely 100% preventable if we were working in the chasm. Okay. And then maternal mortality is just the tip of the iceberg. Of all the things that lead to the near misses, that there are 100 for every maternal death, this is astounding. 22 of the 25 risk factors for those morbidities are disproportionately carried by Black women. Okay. And examples, of course, well, there are many examples. Pregnancy complications, as we said, forlorn future risk. And that's a key point, and are more prevalent among BIPOC women. Just one case in point that our work emphasized, especially in the first phase, was gestational diabetes. I don't know if everyone knows, but 60% of women who have gestational diabetes during pregnancy go on to develop type 2 within 10 years. And Black women are 2 times more likely to have it, and they are twice as likely to develop type 2 diabetes after it. So that's an astounding case in point. And then the third point to really motivate us in this initiative was that care after pregnancy, it can be preventive. It can work to prevent, like we talked about in Dr. Irving's death. And it can also prevent chronic illness going forward, including type 2 diabetes and heart disease. And that's a key point. Excuse me, I'm getting excited. And yet, those at greatest risk are the least likely to receive that care. Okay? I'm sorry. This is just a slide that shows us in the red circle, 70% of women, all women, do not get, after GDM, after gestational diabetes, don't get a test or a primary care visit within a year. And we found in some settings that's worse for women of color than white women. Okay, so now you can really get what so strongly motivated us for this agenda. I mean, developing the agenda. Okay, Irene? So the first thing we did when we got PCORI funding was to establish a stakeholder engagement council. And you can see that there are 5 different, in black, constituency or stakeholder groups. Community advocates, health system designers, clinicians and researchers, communication specialists, and policymakers. We knew all were critical to creating this initiative and carrying it out, developing an agenda that would really be actionable. And you can see who our reps were. Okay, here are the aims. We all decided together, these were our chief aims. Engage and sustain a network of patients, advocates, providers, researchers, policymakers, health system leaders to co-create an agenda to bridge the different chasms, to center voices of women, and to create a platform, and this is where we are now, for a growing movement to support birthing people across the life course and eradicate all the fragmentation and racism that are quite intertwined in healthcare for women. Very quickly, we started with a very fun pioneering conference in July of 2018 to sort of flesh out the agenda. And because we had so many different kinds of people, 75 people came. I apologize for that XXX down below. We have a full list of the participants that we're going to incorporate in the slides when we post them. We started with the first day of improvisational theater, believe it or not. We hired a cadre of very diverse and animated theater artists to take us into groups and walk us through some very fun improvisational activities that would help us break down any walls due to position or status and build trust. And then the best part was to lead us through activities that helped all of us, no matter who we were, to better distill our message, what we care about the most, why we're here. And then to develop a 3-minute, very powerful story, our own story, about what most motivates us, what got us here. And then we shared those stories in a story slam. And that set the sort of the tone for the second day, which was getting down to some hard work. 2 world cafes or roundtables to brainstorm. Okay, here we have this great divide between primary care and obstetric care, and between people who design services and those who receive them, etc. What's the evidence? How can we bridge this period of time, these chasms, what do we know? We had evidence at our disposal, and then we brainstormed. And then really by the afternoon of the second day, people divided into their groups according to themes and began to set the priority, the outline of the agenda, which we then carried forward in the second year. And that's, you can see these 6 categories of themes that we then turned into working groups in the second year that Irene's going to pick up. And we had this to the right, you can see our online portal, which was very useful as we were recruiting people from all the different stakeholder groups all over the country to participate with us. And it was all volunteer. It was the most incredible, magical thing that people stepped up and participated in creating this agenda. At that point, there was no money, and there was just a lot of incredible knowledge, expertise, lived experience, and motivation. And that's what Irene can begin to tell you about.
Yeah, and so all of that motivation was transformed into 6 working groups, again, across those areas that Lois just highlighted that emerged from that first conference. And in order, again, to co-create what comes out of the working groups to make sure that all of those stakeholder groups are represented, there's actually another round of recruitment so that the members represented within the working groups could actually speak toward, again, moving toward what we know are the areas that need to be addressed to how do we actually address them, knowing the evidence and moving from there. So there were 80 members of working groups that formed the Bridging the Chasm collaborative, and each working group had 1 to 2 main, leaders, just to make sure that all of us volunteers were on point and on task, and to lead us through this agenda that you can see here. So each group on those 6 areas in tandem moved through 5 calls. The first one around problem statement, then moving to identifying those system level strategies that have been attempted, and then selecting those strategies that rise to the top as most important and actionable and necessary at this time. And then doing 2 rounds of prioritization in order to make sure that the 4 categories that you see, criteria that we see here, actually informed which ones we would then elevate. So that was prioritizing equity, again, emerging from the urgent need and motivation for this whole initiative, also centering effectiveness, innovation, and feasibility. Based off of that prioritization, the groups then identified the 3 strategies to recommend for the agenda. And for each strategy, we identified potential stakeholders, existing initiatives, networks, and alliances that could move this forward. So that was the working group model that happened kind of in tandem across those 6 areas. And even after the working group process, something that emerged was that there was a lot of synergy. There was a lot of reflection of similar things coming up across these different working groups. So then there was a next stage where the Stakeholder Leadership Council and those working group representatives, so those main taskmasters that were in the working groups keeping us on task, then met together to identify how the strategies were interconnected, and also how we could leverage those interconnections, again, this being a critical part of moving the agenda forward, how we could break down the silos to leverage those interconnections to move forward on kind of collective action and impact. And so the next slide I'm going to show is it's a lot of information, so I'm going to prepare you, but it really is a 1,000-foot view of what the working groups came out of this process of the working groups and the interconnections. And we'll go into kind of the rationale, highlighting key agenda items that we feel are relevant and will inform our discussion. But one thing that I wanted to highlight about this is all of those little spaghetti straps that we see kind of going from the different agenda items really highlight the fact that there is repetition and not necessarily redundancy, but places to leverage for shared and collective action going forward. And so that was also a key takeaway from this process. Not only are there these agenda items, but there are enough robust connections for us to take immediate action to break down silos to actually move these forward together. So now for the next few slides, as we kind of transition, hopefully giving enough time to have some discussion, we're just going to give an overview of the main pieces of each of these working group areas that we think will inform a robust discussion in the final moments of our presentation. So, and the first two that we're going to present on are the ones that we feel like are foundational. If nothing else happens, these two need to be addressed. These two working group areas need to be addressed. And without them, any other actions in other working groups will ultimately not accomplish the goal that Bridging the Chasm intended to set out on. And the first one is eliminating racism and implicit bias in healthcare. Now, the rationale I think many of us can understand is that this is racism and bias in healthcare is rampant and a really stagnant barrier to actually providing equitable care to all women, especially BIPOC women. And in reflecting that, many of the recommendations were around leveraging our accreditation and larger kind of training agencies to institutionalize mandatory trainings that address implicit bias, address explicitly racism within clinical care and practice, and also put into place mechanisms that allow for accountability across the process so that none of this can be kind of voluntary. None of the organizations can opt out of addressing racism and bias in healthcare. The second foundational area that we feel like, moving forward, no action will be ultimately successful if this is not a bedrock of how we move forward, was investing in communities. And the main part of this is that there is a wealth of community organizations led by women of color that are out there doing this work. They're out there providing the critical holistic care that women need before, during, and after pregnancy, but they are not supported in a robust way and in a way that reflects kind of the critical care and the way that they approach care for women across the chasms. And so the recommendations going out of that was to leverage tax break and other incentive structures to bring public and private founders and foundations into the fold, make it their imperative to support these organizations in the work that they're already doing in a way that amplifies their work and provides them with the support over technical assistance and other domains that's needed to, again, continue the excellent work that these community organizations led by women of color are doing. So I'll hand it off to Lois for the next two working group recommendations. Oh, I think you're muted.
Thank you, Irene. I'm going to go really quickly here. The real point of this working group was to acknowledge that we do have what we call high-touch models of care during pregnancy, and these need to be extended long after, up to at least 1 year postpartum. And one of the ways that can happen is through policy. So this group and the policy work group overlap a lot. And I want to first say I misstated here Center for Medicaid Innovation. It's Center for CMS, the Medicaid Center, and their unit of innovation has a lot of potential here for our advocacy, by the way, to create incentives for the kind of collaborative team-based models of care that include doulas and community health workers on the clinical teams, if that's desired, if doulas choose to work in that sort of environment, and to require those in the context of accountable care organization designation. And they also have the ability to set up ways to innovate and fund group care, such as centering pregnancy, but make it centering postpartum care throughout the first year for those with pregnancy complications that need each other's support and absolute assurance that they're tuned into primary care, or to support doulas as essential, not only maternity care workers, but also to structure the reimbursement that it could last longer across the chasm and up through at least 1 year postpartum. And then policy, similarly, I think this has gotten a lot of attention lately. We absolutely need to extend Medicaid to 1 year for those who come in under the pregnancy eligibility criteria. And then we just have to get to it and have quality metrics that bring people's feet, clinicians' feet to the, hold clinicians' feet to the fire when it comes to doing something like what we call a warm handoff, or making sure that every woman who finishes her pregnancy, especially those with complications, get directly connected to a primary care provider. I'll just say that for policy, there are, as you can imagine, there's a long list of policy recommendations in our full report and articles to come.
And to round it out with our final 2 working group recommendations, this 5th one was around preserving the narrative, especially how do we leverage health system innovation or the lack of health center innovation that often erases women's voices within their own care and provides a consistent barrier, again, of centering women in their own care. And so the recommendations here were around leveraging technology in multiple ways to bring women's voices explicitly and uneditedly back into their own health records, and also leveraging technology in order to create kind of a dual communication bridge so that women can, access the tools and metrics that they need in the postpartum period to, again, make sure that they can engage in the ways that they want in supporting their own care over this period. And the second another recommendation was around legislation to standardize maternal mortality review, but critically, ones that center including family interviews so that we understand, again, women's voices in the trajectory of what happened, and around mortality incidences, but also around morbidity incidences, which also need to be more brought into the fold when we're reviewing this critical window of this critical chasm, this critical window across childbirth. And the final one is really around research needs to reflect the fact that holistic care is needed in a more comprehensive way. So from funding structures to the ways that institutions actually structure research. So not breaking it up into different body systems, but really seeing women as the holistic individuals who they are. That needs to be reflected, again, structurally and sustainably in funding agencies. And mentoring and funding, this last point, mentoring and funding sources should amplify and center the support of women of color in leading these research efforts. So that's just a 1,000-foot view of what came out of those working groups. And I'll hand it off to Lois to round this out and bring us into a brief but hopefully robust discussion.
Thank you. So we're in a very different place collectively than we were in July of 17 when we thought to apply for this grant, and when we held the conference in 2018, as framed so beautifully by Irene. We're in a different moment now, and we have been in a way in this regard since Black maternal mortality the news of its injustice began to spread like wildfire, finally, in the mainstream media. And Black women-led advocacy groups are leading the way. And it is so remarkable to me as somebody, I've watched this fragmentation happen for so very long, many of us have, to see that we are where we are. And we have a platform now for this chasm to become known, and its contribution to death and chronic illness that's preventable, and to leverage the legislation that's already pending. So next slide. Many of you are probably very familiar with the Black Maternal Health Momnibus Bill. It's one example, but the main example that has a really wonderful chance of passing, fingers crossed, our election results. And it has, because of the Black Women's Health Caucus in Congress, and because of the incredible work of organizations like Black Mamas Matter and NBEC and many, many others who are doing grassroots work across the country, that it actually has a chance of passing. So what I want to challenge us with is how can we be sure that when such legislation speaks of pregnancy, rounding out pregnancy supports, that we make sure it includes language that always goes forward at least till a woman gets to primary care. I missed the chat. I think there's a message, but here's the question we want to pose to you in what I think is fun. Do we, our host, do we have 5 minutes or 6?
Yes, I'm going to go ahead and post. Yes, I'm going to post the question in the chat as well.
Okay.
People can see
So
it.
we would love to hear from you, from your vast experience and expertise. What do you see? What resonated with you? What do you see as the most important next steps to get women, make sure we can get women across this chasm specifically, but in then the big picture, really eradicate racism and the fragmentation, because fragmentation is a form of racism, the way that it really works in the world. And if we keep treating women like body parts, or all birthing people like body parts, one siloed system at a time, we are not going to have a sustainable, holistic, and very institutionalized way of caring for women, as we well know. So we want to open it up. What is to take it back to Irene's metaphor, what do we want to be sure to take through the portal, both during COVID, but certainly after? What?
So I see in the chat, just to start us off, someone shared, or Rose shared, breaking down the egotism that is part of medical training and the fear of speaking up with those who are supposedly quote unquote in the know.
It would be our hope that required competency-based and not one-off, but longitudinal training, inclusion of that kind of agenda in all medical, accredited, and nursing, and nurse practitioner, etc., is, it's required for accreditation.
We also have from Angela in the chat, incorporate and elevate more women of color into patient advocacy roles, research roles, and paid community advocate roles. Not just any women of color, but those who have clear, authentic, expressed interest in this specific agenda. Thank you, Angela.
Yeah.
Anyone else want to share?
And while comments are coming in, there's actually one question from, I think, Stephanie that I'm seeing. That I think, Lois, it would be great for you to take on. She was asking, how is the community engaged in creating the working group recommendations? And do we have any metrics that show how the implementation of the efficacy of these recommendations, or do we have any metrics that you're planning to follow? Which I think is integral to kind of figure out, like,
it's a really, it's a great question. I mean, to be honest, the only metric we have in terms of engagement was who is engaged and how. The how is that they participated in the working group. The who is, appears on the list that we will make part of our posted slides. And the other is kind of, but I think, if we had a more robust kind of initiative funding source, we could have done an evaluation of it that went beyond, asking people how it went. And I certainly think that would have been terrific. But we didn't. And so the evaluation is kind of just going to be what happens with it. And not just with it, this was meant not for us on these working groups to carry out, but to send out into the world and hopefully some of the ideas are new and can be latched on to existing ideas and existing legislation. The other thing I want to say is we do have some articles that everyone authored. So we have 70 authors on a policy piece that we've submitted to a women's health journal. But we don't know if it's accepted yet.
But I think that goes back to the radical way in which you do this differently. Whereas, there's always pushing the limits of how do we radically include more of the community. But I do think that this initiative definitely was including, Black women, the voices of community-based organizations, doula organizations, all of that. And there was a robust conversation, at least when I wasn't during the whole process, but at least at the report development, all of that. How do we not only represent everyone in this work, but what is equitable authorship? What is equitable exchange of, right? There's knowledge production that's happening on that end. So how can this feedback and amplify in all of these different areas, the women who are bringing this knowledge to amplify the day-to-day things that they need brought forward. So I think that's another part of like this community engagement. Again, as Lois mentioned, the evaluation part, more money to do that is always key. But I think the intention of this was to radically push forward robust community engagement.
Thank you. I wanted to openly acknowledge Maureen's comment. She says, I'm a lactation consultant and continuity of care is a huge issue. Having community-based workers, doulas, or peer pregnancy coaches or navigators would help families greatly. The time between hospital discharge and first pediatric appointment is no man's land, and new parents are lost and left hanging. So sort of in response to your question before, she said, we also need to reduce barriers for BIPOC, I think people say BIPOC, birth workers and getting access to training who wants to go into this work. We also have from T, I was going to add that we need BIPOC workers, birth workers, to have full support with trainings and education. There's just not enough representation, and Maureen said it best. We also have a couple questions. I just want to go ahead because I want to make sure that they're heard. I think one is extremely relevant. They're both extremely relevant. One, as with any collaborative, creating a manageable agenda, keeping volunteers engaged, and finding funding to support the work can be a challenge. How did you navigate the whole where's the money question that we all sort of have when we do this sort of work?
I have to be honest, there was noise in my home, so I had to look away for a moment. Could you just say the last part of that again, Heather?
Yeah, sure, no problem. How did you navigate where's the money question? So there are a lot of challenges presented with this work. How did you solve that or approach that?
You mean where's the money to make this happen? Whoever asked that, or where's the money to just get the initiative done? To make the work happen?
I think to make the work happen.
I mean, that's a great question. We did try to be very concrete in making recommendations only with levers noted. That is, who does what, which targeted action players, which policymakers can do what. And that's why a lot of attention was given to Medicaid, CMS, in ways they can bring incentives to the fore so that institutions like accountable care organizations can have to create these kind of collaborative teams, for example. And then, as you saw, private philanthropy funders, we would aim to hold their feet to the fire through requirements, or not requirements, but incentives of tax breaks offered by the federal government. So, each recommendation had us looking at, okay, where's the money going to come from to do this? Or where's the power? Where's the power? The money,
Just some reflections. I think that was like, it was something, at least so I was in the policy working group, we really wrestled with like the money, not only as Lois was talking about, but like sustainably in a way where this isn't just one-off initiative or whatnot. So again, I think that was not a sticking point, but a sticky point, right? For how do we disentangle, structures and systems of financing that embed and make sure that this, fracturization and racism is continuing. How do we buck that and in meaningful ways, right? And that's the imagination, and that's like the portal.
So I think we have time for one last question that was sent anonymously. How do we advance work through the portal, quote unquote, of COVID when we are simultaneously experiencing radical racism? I mean, might be a lot to unpack, but maybe we can start to unpack it.
Yeah. Do you want to have a go, Irene?
Yeah, I was going to say, I think what comes to mind is leveraging this moment of truth telling, because again, kind of as we've seen dual what can happen, how much energy and passion and effort can be leveraged when we collectively work. And again, you know, we can all have our opinions about how this is sustained, but collectively work toward addressing the pandemic of COVID. But at the same time, seeing this stagnancy really brought open this moment of how much we're really not. Like, are we really committed to bringing forth the things about racism? It opened up places and a moment where we can be radical in saying, you know, there's no more time for lip service. If the institutions that are putting up are saying they're behind Black Lives Matter, they're behind the George Floyd uprisings, they're behind what's happening with Breonna Taylor, they actually have to have action that's in a sustainable way. And I, you know, it's not a perfect answer, but I do think this moment, again, we're also in so many disruptive spaces from just our systems, our life as normal being just changed and shifted. I think when we go back, it can't be going back to quote unquote normal. And I think it's bringing forward, and that's why I think for me, I've been connecting with, you know, in my work and, you know, other spaces, you know, what, again, this collective impact. Who are the people that are going to help move this forward? How are we going to amplify synergies in this moment so that we can actually go out and then move forth on this radical kind of change? So I, you know, I don't think it's perfect, but, you know, as long as things is broken, let's, you know, build something new.
Let's do what we can to fix it. Thank you so much to our esteemed guests and presenters, Dr. Headen and Dr. McCloskey. Snaps, claps, all around.
Thank you.
Thank you.
Thank you, Heather and Tanayo, for hosting us. And thanks, everybody.
It was an honor.
When we post our slides, we'll also include our emails.
Perfect.
And if anyone would like to chat with us further, we're glad to.
Quick announcement before you all head out. First and foremost, thank you for tuning in today. Our next session will be next Wednesday. You'll get some emails about it. Make sure you look out for those. Please post on social media, # Birth Equity, # PCOR, # NMHPN. Usually what we would do is we transition into our sort of night meditation, but unfortunately our facilitator is under the weather. So I will guide you in a one quick like breathing exercise. You can feel free to hang up, where we're just going to inhale, hold it for 2 seconds, and exhale. So inhale, 1, 2, maybe 3 seconds. Exhale. We're going to do it one more time. Inhale. 1, 2, 3. Exhale. Thank you so much for joining us today. My name is Heather Olden. Thank you for coming. Have a fantastic evening and rest of the week. Bye-bye, everyone.